Okay, Assalamualaikum and a very good morning to all. Thank you for attending today's CME. I will be presenting on the topic of basic airway management, prepared by me, supervised by Dr. Munirah. Okay, so under this topic, we're going to approach a few things, which is the airway maneuver, oxygen delivery apparatus, airway adjunct, and also laryngeal mask airway LMA. So, in managing airway, there are three basic target in airway management, which is the first one. We want to make sure the airway is patterned from any blockage or any foreign body. The next one, we make to ensure no secretion. So we have to do suctioning, make sure there is no vomitus. And the third one is to make sure there is adequate ventilation and oxygenation. So the culprit in most cases of blocking the airway is usually the tongue in case of unconscious patient. So most of our airway maneuver is actually to ensure that the tongue doesn't fall backward and block the airway. So we have the first maneuver, which is one of the most common. Which part of the tongue is blocking? Oh, only
Mouse ni. Ini.
Okay. So, sorry, is this side. There. You see, in this unconscious patient without the airway maneuver, the tongue has fallen backwards, blocking the oropharynx backward here. So when we do the airway maneuver, we open up the airway at this area so that patient can breathe better. So the first maneuver we will learn is head tilt chin lift maneuver. So basically we
Sekejap, untuk yang online boleh pinkan apa dia account CME EDHSB untuk nampak tengok apa dia demo.
Basically, when patient is in supine position, unconscious, we tilt the head and lift the chin up. So in doing so, we actually move the tongue upright, so remove the blockage of the tongue. However, this maneuver is contraindicated in cases of C-spine injury. So when you are having patient with C-spine injury, don't do this maneuver. Instead, we do the next maneuver, which is jaw thrust, achieving the same target, but with different maneuver without moving the cervical spine. So we want to sorry, I just did it. Yang head tip chin lift tu dia bukan head tip only or chin lift only. So it has to be together. It's together. So the head tilt and chin lift. You lift the chin. So it's not enough that you only tilt the head. It's not enough that you only tilt the head or you only lift the chin. It has to be together. Okay, so next one, we're going to do the jaw thrust maneuver. In case of jaw thrust maneuver, we don't move the cervical spine. So we translate the maneuver anteriorly. In doing so, we actually move the lower teeth in front of the upper teeth. In this case, the same objective is achieved, in which we translate the tongue anteriorly, removing the blockage of the tongue from the posterior side. Okay. So this next one. So you punya this one. It depends on whether you punya tangan, the one yang you letak atas patient punya ni, what's called it? Pendula, kan? You can either, kalau tangan you besar, you can actually just use your thumb. Okay? That means you letak macam ni and then you lift up. Macam tu.
So the movement yang you nak adalah the lifting of the chin, the jaw macam ni. This is what we're gonna tak nampak. Okay, you akan tak apa, kita buat kemudian. So, kalau tangan you besar and it's very strong, you can just use your thumb on the maxilla ni. Tapi kalau tangan macam tangan Husna, dia kecil je. So, tangan Husna, dia akan letak the thinner eminence ni, the thinner eminence on the maxilla kat sini. Okay? Alright? So, that one will work as the fulcrum yang akan menginjakkan benda tu. And then your other finger is going to hold the jaw and angkat the jaw macam tu. So you punya lower incisor is slightly in front of the upper incisor. You nak angkat the lower jaw tu. So that will move your the tongue away from your the airway kan. Okay.
We have
Nak add on sikit sebab nak tengok banyak yang dia pegang dekat soft tissue sini. No, yang ni yang akan closekan mouth dan obstruct airway lah, tak achieve the purpose. So memang kena dekat morning prominent. No, yang atas dan dia akan turut sini, bukan dia angkat dulu tutup mulut ke. Dia akan naik dulu.
So we have the triple airway maneuver in which we combine the head tilt, chin lift, and open the mouth. So when we head tilt position, we show thrust, we open the mouth with the tongue. This is the triple maneuver.
Jadi kalau tak ada sebenarnya tu lah kan.
So when we always heard about sniffling position, but what is sniffling position? Sniffling position is to achieve the alignment between the oral, the pharyngeal, and also the tracheal axis. In patient that is unconscious, usually in this supine position, all the alignment is misaligned, not in the one parallel pathway, not really parallel, the one we achieve it. But when we do the sniffling position, what is sniffling? Sniffling, yeah, sniffling, sleep. Then we align it to achieve the ear to sternal notch punya horizontal line. So in case of adult patient, usually there is some form of space. That's where we sleep with a pillow down here. So in order to achieve the sniffling position, we put a pillow down here so that the ear and the sternal notch is in one horizontal line, achieving the sternal. However, this is different in different age group. In children, however, next slide. In children, however, the sniffling position is not achieved just by simply putting a pillow down here, because in younger, especially in infants, they have a bigger occiput. In this, because of the bigger occiput, when they lie flat, the neck tends to go this way, go like this. So they're blocking the airway. In achieving a sniffling position, there are three. First, you want to horizontally align the glabella and also the chin plane. The glabella and the glabella and the chin plane. The neck we need to keep wide open, and also the same one, the ear to the sternal notch. So in terms of infant, we put younger infant. We have to test it because some children are bigger than the rest. You have to test it in order to achieve all these three categories to put the patient in sniffling position. Usually in infant, you put a headrest and shoulder roll so that you achieve all these three: wide open neck, horizontal between the ear and the sternal notch, and horizontal plane of the glabella and the chin. However, when we see children at about 8 years old, sometimes in children like this, you don't even need a pillow because the sniffling position is achieved without even putting a pillow for this patient. However, in this, you see the sternal notch and the ear is in horizontal plane, and we have the glabella and chin plane achieved, and the neck is wide open. Then we have another group in which patient is obese, in obese patient, in order to align their airway, we have to do a maneuver called ramping, because they have a bigger torso, which means you are unable to align the ear to the sternal notch. Ramping is not usually we do in ED because we don't have the OT bed. We put multiple like saline blanket in order to achieve this. It is not simply like we put patient in a prop up patient because the head is actually prop up and you see, when you do on through elevated pillow, then put head cradle, which means you prop up patient, then the head is flat. You achieve the alignment of all the oral, pharyngeal, and also tracheal punya axis, achieving a sleeping position. This position is good in case of patient with obesity because it can ease breathing. Because usually when I see patient with obesity, they tend to have multiple pillow because it ease their breathing. And next, it can also increase the oxygenation, in which you have a longer delayed desaturation when you try to intubate the patient. Because the patient is elevated, sometimes it makes it easier in case you want to make bagging the patient and also attempt intubation.
So tak payah nak. Now kan what you all do when you want to intubate patient, you all flatten the patient down. You know, the patient was elevated, sitting up nicely. Suddenly you got apa? Head down terus, flat terus. Betul? Betul tak kau buat macam tu? Tak buat macam tu. Kau ramping ke tak? Tak ramping lah kan? So apparently it's the best. Buhe apa? Bed up.
Head elevation.
Head elevated kan? So that's the best position.
Kena intubate patient yang more than 400 kilo. Or 200 kilo. No, paling besar dia. Ada tak? Dia no idea tapi.
Okay lah.
So the paling umur lah you all intubate patient tu. I mean, so macam mana selalu you intubate patient yang you pernah, yang patient yang paling obese you pernah intubate tu sebab apa selalu? MBE ke, pneumonia ke apa ke? Pneumonia. So jadi yang you pernah intubate tu patient pneumonia. So waktu you bed performance patient tu macam mana dia punya oxygenation? Free oxygenation pakai lepas tu terus intubation. So tak ada masalah lah. Okay, so pernah reset tak patient? Patient yang saya intubate yang gemuk dengan ada intubate. So pernah reset tak lepas tu? Lepas you intubate tu di pillow patient hypoxia tak ada. Okay. Kurang bagus lah. Okay, so dia ada cara, especially yang patient yang morbid obesity, yang 200 kilo semua. Okay, so yang memang tak buat katil. Okay, so dia ada cara dia.
Tapi kalau kita cover pasal RSI next.
Dia want to AV juga, tak apa, cari after this.
Okay, so when we're dealing with basic airway, we have a few airway delivery apparatus that most of us use daily in our working life. First, we have the nasa cannula, which in books say that we can go up to 6 liters per minute. Delivery oxygen approximation about 21 to 44%, and it increased flow rate by 4% per 1 liter increment that you add. Then, however, the oxygen concentration depends on the flow, the pattern of ventilation, everybody that we know of it comfortable, and which means flow rate. So they will have the face mask which can go up to 10 liters, 10 liters, delivery oxygen about 35 to 60. The oxygen concentration must have a tight fit of the mask, oxygen flow rate, ventilation of the patient, and the inspiratory of the patient also. Venturi mask. When we talk about venturi mask, usually we think for COPD patient. So it gives a specific desired oxygen concentration to the patient. That's why we like the venturi mask. In venturi mask, it used the principle of Bernoulli's principle, in which the oxygen flow through a narrow passage, in which it causing increase in velocity of air. Increasing velocity of air causing negative pressure, which in turn entrapment of the surrounding air. So this is the Bernoulli's principle. Why we like why in venturi mask
elect COPD patient instead of a higher percentage of oxygen. There are two main reasons why. First is in COPD patient, their lungs is already diseased. So they have a certain coping mechanism in which the oxygen is directed to the good parts of the lung. In which if we give higher oxygen concentration, this balance will be shifted, in which the more oxygen will go toward the diseased lung, because the gradient, you see, this side no oxygen concentration, so the oxygen will be directed to this diseased lung. However, the diseased lung cannot ventilate, cannot give a good gas exchange in this disease lung. So that's why patient got hypoxia. So in terms also patient have in COPD patient, they are used to a higher concentration of carbon dioxide in their blood. So they use the hypoxic drive to breathe. In which you give higher oxygen, the hypoxic drive will be reduced. However, because of the first reason, oxygenation is not enough, so patients subsequently reduce the ventilation leading to hypocapnia, hypoxia. So we have the high flow mask, which have rebreathing and non-rebreathing. Differences between the two is the valve, in which it has the valve. It is non-rebreathing. It is non-rebreathing because when you exhale gases go out, so that the oxygen that you receive is purely oxygen from the reservoir. However, if rebreathing mask, you inhale back the gas that you already exhaled. So it's a mixture. So that's why there are differences in oxygen approximation. In rebreathing, about 70 to 80, non-breathing about 95 to 100%.
Jadi kalau guna high flow mask tu apa benda? High flow mask apa hari ni? Ni yang duk guna ni yang duk tak biarkan ni. Yang high flow mask dia ada guna rebreathing mask ke non-rebreathing mask ke apa? For it to be non-rebreathing, apa yang kena ada? Tak ada lubang. Apa yang kena ada? Kena ada valve. Valve ada berapa? Kena ada berapa valve? Untuk dia nak jadi non-rebreathing. Non-rebreathing maksudnya dia tak sedut balik dari CO2. So it's 100% oxygen lah kan. So for that to happen, the mask has to have how many valves? Dua. Dua kat mana? Dua kat tepi ni kan. Di kiri kanan kena ada. Lagi satu kat mana? Lagi satu dekat bawah. Dekat from the oxygen reservoir to the mask. If you tak ada, if you ada only one, then you akan compromise lah the amount of oxygen. It's not going to be 100% oxygen already lah. Betul Jimmy? Okay, so dua ni kena ada so that from outside tak masuk. And then yang dekat bawah ni, dekat bawah kena ada so that the CO2 that is exhaled by the patient does not mix with the one the oxygen in the bag. Nah? So kalau dia tak ada tiga tu, that is not non-rebreathing. Maknanya yang depannya hypomas tu is that lah. Nah?
Then we have the AV adjunct. There are two types. Here is oropharyngeal airway and nasopharyngeal airway. Based on the names, you know, it is inserted into different part of the region lah. So for nasopharyngeal airway, you insert it into the nostril, while the oropharyngeal airway inserted by the oral pathway. So in case of we go with the oropharyngeal airway, there are many sizes to choose from the oropharyngeal airway. However, in choosing the sizes, there are two different
Indication, betul nak?
Indication in order to keep the tongue anteriorly also, because it will sit like this. It will sit like this. A beaker will cause it to block the airway instead if you choose a different size of an oropharyngeal airway. So it is contraindicated in patients that have gag reflex. So conscious patient, you cannot put this because it will cause patient to have gag reflex, subsequently vomiting, aspiration. So don't use in patient with gag reflex lah. So
patient yang macam ni yang nak berbual ni, apa ni? Patient clinically, how would they appear? How would you know that they have an occluded airway? You only put this in the patient with occluded airway. So how would they manifest clinically?
Clinically, patient akan tachypnea, then maybe stridor.
You have stridor, then Definitely they have labored breathing lah, but mainly the strider will tell you that there will be some sort of an adjunct to the airway. Ataupun it can be together with your bagging. You're gonna bag a patient to keep the airway open instead of you using your hand maneuver, so you can put that thing in so that it helps with the airway occupancy. Yes.
So when we choosing OPA, the measurement can be two. Each one is bone to bone, sock to sock lah. So we go because they will sit at the front of the teeth. So from the incisor to the angle of mandible. So to the angle of mandible. This is just the correct sizes for this mannequin lah. However, if you choose a much bigger size, it will not sit at the angle of mandible. Instead, it will occlude the airway as I told you in this. However, we choose a smaller one. The smaller one will not achieve the target that we want also lah. So we need to choose the appropriate sizing. Or the other way is we can do the tip of the mouth to the earlobe lah. Tip of the mouth and the earlobe. Okay. So
Angle
of mouth. Angle of mouth. Okay. So when we inserting this, you want it to sit like this. However, when you inserting it, you first insert it backwards. We open the airway, insert it backwards. Then we twist. Once you halfway in, you twist 180. Subsequently, it is in. So you then you ensure that it's better. So this is for OPA. Then we go for NPA, nasopharyngeal airway. Nasopharyngeal airway also is actually to provide a passage of airway. Yeah, it is contraindicated, however, in patient with vessel skull injury.
Oh, is there another way of inserting an OPA?
There's another way of using OPA in which you don't have to twist. You can insert it directly in the pathway it is intended using thumb depressor. I don't have a thumb depressor. You press the thumb and you just proceed to push it in this way.
So especially in pediatric, in pediatric you jangan guna the twisting because they've got a very somewhere you can easily injure. The babies tu jangan guna yang twist punya tu. Teknik tu kan, lepas teknik tu kan.
Then when we are choosing the nasopharyngeal airway, usually the diameter we choose is depending on the pinky of the patient, not your pinky of the patient. So when we want to measure this, it is from the tip, from T to T, from tip of the nose to the tragus. So you put it. So this is the correct sizing. However, when we try this one, it is exceeding the 1.1. So when we're inserting this,
Kalau panjang dia apa? Dia akan masuk and induce the patient to get. Sebab dia dah sampai kat oropharynx dia. You should stop dekat nasopharynx saja. So if you put too long, walaupun dia masuk dalam hidung dia, slightly your time patient macam tu kan. Because this one you use because in a patient yang might have gap. So kalau you buku yang panjang sangat, you don't get, then if it's purpose, you might as well just put the open kan, itu salah lah.
When using nasopharyngeal airway, we have to lubricate the nasopharyngeal airway. Choosing a good nostril, make sure no deformity in the nostril. So don't use the one with the deviated septum or something. Choose a good nostril, then you lubricate your OPA.
Jangan lubricate sampai tutup. Dah lumen lah. Lubricate sampai tutup, habis lumen. No, nanti saya nak makan.
So when you are inserting, it is ideally there is a tip that is waxy sharper and try to keep the tip away from the septum, because in the septum there is little area which easily induce bleeding. So we try to avoid putting the tip. Just push it in because it will go the intended passage. Because there's only one way in.
Next, we have the back mask valve. This is something that we use. We often call it hammer back. Hammer stand for siapa tahu? Very good, no? Addiction manual breathing unit. AMBU, ingat kan?
Oh, ingat kan?
So then when we are choosing the mask first, we need to choose a correct and fit mask qualification. You target nak hit from the nose, this of the nose, sampai dalam mid of the chin. You need to cover all this area, ensure tight fit. If you don't have a tight fit, I don't think you're not going to achieve a good back mask ventilation later on. So back mask ventilation is used to administer a high flow of oxygen, and you can provide feed by giving some pressure to the bagging. Controlled ventilation and augmentation or spontaneous ventilation do some improvements. So you need to give adequate cover, and sometimes in certain patients, there will still be leaking. Even though you choose the correct sizing, they are leaking. In cases patient yang ada beard. In cases yang patient ada beard, you don't ambil pisau dan start shaving dia. You can use KY jelly. Use KY jelly to a bearded man. Then we also, in patient yang ada dentures, usually bila you remove dia punya dentures, the cheeks started to sunken because dia punya gigi tak ada kat dalam. So in case patient yang you nak bag, you just keep the dentures in. That way dia punya pipi akan stay on top. Akan stay. And also, unless the dentures tu dah loose. Ataupun kalau patient tu datang macam dia ada dentures but not wearing one, then you can help to puff up by putting some gauze inside the cheeks. The buckle jangan insert dalam. That way you don't occlude. They will put inside the buckle area here, inside, so that you can achieve a good tight masking. So there are a few techniques when you want to hold this mask. We have the single hand, the double-handed technique, 2% lah, because you have two things you want to do. You want to hold the mask, you keep the tight fit, and also you want to bag. So first technique is ensuring the tight.
Jangan push atas muka tu.
Ada lagi satu yang selalu buat kalau you bag patient before your assembly tu betul lah ketatkan. Let's say tengah bag tu tetangga janganlah letak kat atas
Muka patient.
Angkat mask tu. You tak atas muka patient tu pun takkan masuk pun.
We talking about CE or CE clamp kan. C is when you hold the usually you back with the dominant hand. Because C is on the mask, E is on the maneuvre. Can you see the C and the E? C, you do like slight jaw thrust to improve the airway. Then you can back the patient. You can see chest rises, ensuring that you have a good ventilation for the patient. Then we have a double hand technique in which we have to got another person helping us. Then the same sneaky technique, just doing it with both hands. So
you tengok kalau you tak buat proper, because syarat sah you nak dapatkan tu, syarat sahnya adalah you kena ada, first of all, your airway has to be patent. Okay, you dapat seal terang mana pun, tapi you airway you tak patent, maksudnya you tak buka the airway. You do not perform airway maneuver. You only ensure the seal. That is not good enough. That's not going to get the air in. So macam you tengok, for example, you tak buat airway opening. You say there's no chest expansion. Walaupun Husna tengah buat good seal. So now you do a good airway maneuver. So you have to lift up like that nicely. Okay. Now you can see that the chest is expanding. Okay, katakanlah tak boleh juga sebab tangan Husna ni, ya Allah kecil, tak larat dah 3 jam lah doktor duk pegang patient ni.
You
Teknik.
do a VE. V, you using the just like this now, but you nak buat jaw thrust. You compress with the pinna eminence and you shift.
Yes, nampak? So pinna eminence tu yang tekan dekat patient punya maxilla. Okay. Should you start from one hand to two hand to two, macam mana? Modify. Should you start with that ataupun you should just go straight with this? You go straight with this. Kenapa you nak buat benda yang nak melitihkan dan melewatkan survival question kan? So you buat terus dengan ni. You terus start dengan pinna eminence, this technique. This should be your first initial technique. Okay. Saya tak dapat juga Dr. Husna. Tak dapat juga. Tak dapat juga chest expansion You're begging the patient, you can't get a chest expansion. What's next?
Next we have this supraglottic airway.
Sebelum tu, you can insert your OPA and your NPA. Sebab kadang-kadang the limitation with airway maneuver adalah letih. Okay, especially kalau patient ni besar and tangan you kecil. Okay, so kalau you tak dapat good chest expansion with the 2-man technique, you pasang OPA and even 2 NPA pun boleh. Okay, so you letak OPA. Ini salah tak macam ni terkena Kau tak boleh ingat. Macam tu. Lepas tu you letak lagi bubur semua ada. Lubang mana ada bubur. Tak ada gel lah pula kan. Macam tu. Bubur tak apa. Bubur. Gitu. So now instead of you needing to use so much of your energy and effort to open up the airway, now the OPA and the NPA is going to help you. So the airway patency is ensured. Okay, then you focus on the seal. You focus on the seal. Because ini tak apa dah, dah memang buka dah. Then your mata focus dekat chest expansion tu. So you get that. Okay? Right, boleh Okay, then I'm going to move on
Kalau patient obese tu kita macam mana nak ensure good ventilation patient ataupun very fat dengan patient pregnant ataupun patient pregnant has a big breast. So macam mana you nak ensure good ventilation? Sometimes okay lah, you can say itu big patient, tapi patient yang HIV dalam not good ventilation. Patient survive tapi HIV. You ramp the patient up. So macam mana nak ramp up patient yang obese ataupun yang pregnant yang very big, huge, big breast. So what do you do with that kind of patient? Okay, that one is to open up the airway. So let's say the airway okay. Now problem dengan ventilation because of the deep breath. Because of the morbid obesity, big tummy. So dia akan problem dengan ventilation. So airway okay lah, you dah okay, patient boleh airway dah patent. You patentkan airway dia. So sekarang ni you nak lung expansion tu tak bagus. So macam mana you nak improve the lung expansion? So the technique of airway ni ada dua. Satu okay lah airway, nak open up airway semua. Tapi untuk back from front is airway and ventilation. So macam mana? Airway you dah okay lah, pandai dah you all tackle the airway. Now ventilation. So macam mana? You akan pop up. Okay, so let's say lah. Okay, so you pop up patient gemuk. Okay, patient ataupun patient pregnant. Okay, so you pop up 45 degree ataupun 30 degree. So what is the mic? So ini patient, ini patient, ni perut dia. Okay, so selalunya you have macam ni. Lepas tu you macam tu kan, you pop up kan. Okay, so dia punya chest, you pernah tengok lah, you tengok kan patient yang gemuk. So bila dia pop up, what will happen? Patient sedap. Itulah you pop up, you sedap. Tapi yang patient yang very big, huge abdomen, so macam mana nak buat? Okay, So sekarang ni bila you tengok kalau patient yang tu dia pop up macam tu, of course lah SPO tu tetap dia akan turun by gravity. So kalau yang patient yang perut dia macam tu, so yang very tense ataupun dah ada compartment abdominal compartment syndrome. So dia punya diaphragm akan splinting kan, because of the increase dia punya abdomen kan, intra-abdominal pressure. So macam mana nak buat? So bila patient yang increase in compartment pressure, dia duduk, dia tak boleh duduk, dia akan mengiring tau. Pernah tak macam ni nak intubate left lateral. So alright, so sekarang ni so how to increase dia punya ventilation? So by gravity. So you pop up 30 degree sahaja, bukan pop up. You rem macam tu. So macam tu kan tremble. So macam tu. Tapi jangan 45 degree, tak jatuh. So just sikit je. Nanti degree. 30 degree. 20 to 30 degree, maximum 30 degree. So dia akan jadi macam tu. So dia punya abdomen yang flabby, yang semua tak akan jadi turun ke bawah. Lepas tu by gravity, dia punya lungs akan expand. So that's to improve dia punya ventilation, to prevent dia punya hypoxia apa semua tu lah. So kadang-kadang selalunya you berjaya semua, intubate semua berjaya lah, semua berjaya. Yang tengok HIE. So kita tak nak HIE. So kita punya aim, what's your aim untuk intubate patient ni? What's your the patient discharge well? So that's the end punya goal. That's your end goal. Patient discharge well. Not patient discharge vegetable. You berjaya macam surgical lah. Operation berjaya. Tapi semua patient berjaya, tapi patient vegetable. So your end goal is patient survive back to dia punya own morbid. So that's how you take the patient from morbid obesity. So sekarang ni dekat HSP, you all kenal sebab you ada feedback. So kalau yang kalau you kena campak ke mana, ataupun if you want to be a specialist, you need to master how to intubate without CMAC. CMAC ni senang je, buka kan, nampak je. Thank you.
Faham tak? Okay, jom, moving on.
When we do EMV back mass ventilation, there are certain mnemonic that we use in order to ventilation yang akan ada difficult back mass ventilation, which is the first, the muscle, which we already tackled just now with the KY jelly on the ventilation, that if there is any fracture of the facial.
Let's say kita letak KY jelly ni, sama satu dia letak KY jelly, back still ada. It's a jelly, it's a gel. So still ada boleh nanti apa lagi you buat? You put gauze kat bawah. Gauze ada air juga.
Terkadang.
Tak plaster, tak terkadang. So kalau dia senang letak terkadang buat fitting. So you get what?
Even patient yang obesity or obstruction, patient yang ada contoh macam swelling over the neck, dia adalah angina, ataupun patient yang mungkin akan ada difficult back mass valve, age usually elderly, usually kat point yang more than 55 years old lah. Sickness mau
Masa dah seng.
masa dah.
Oh, 55. I'm not yet.
Banyak minum collagen untuk
Oh, tak ada isi lah
tak ada isi. So kalau untuk yang age tu selalunya macam elderly kan, nampak dia dah sagging. So another method you boleh just cepung tarikkan, macam buat facial, tarikkan. So untuk sealkan tu lah.
Bawa pipi dia ke tepi the edge of the mask, ke atas.
Ke atas macam. Okay, next.
Patient yang tak ada gigi ataupun yang ada skizofrenia lah.
Dia punya encounter patient yang keras tak, yang diagnosis.
Yang tak boleh, yang keras. Yang mana? So macam mana? Dia lah. Mana boleh? Patient morbid ni well, macam okey je. Just spondylosis. I mean, spondylosis. Apa nama? Yang dia spine tu.
Ankylosing spondylitis.
Spondylitis. Macam TPK yang lain.
Dia sebenarnya before you bagi you punya masa relaxant, you should always test whether you can back the patient. Walaupun you did not back the patient before, you tak rasa pun perlu because patient can saturate well. The patient is doing the pre-ox well on their own. They have got a good effort. So you dapat 100% pre-ox. Tapi you should still test whether you can back the patient because prerequisite to you giving the muscle blocking agent. Tak? Sebab tadi bila you block the muscle, dia tak boleh breathe. In case of failure of intubation attempt, then you need to back kan. So that's not the time that you want to test. You want to test before you give the relaxant. So kalau macam yang kita tanya tu, macam mana? Keras-keras semua tu tak kena nak buat airway maneuvre tu. Your trust. Lepas tu? Lagi? Opakan dia.
Yang tu betul. Jangan
Nak ambil lain lah, it's a crash intubation.
you dah tahu yang tu.
You prepare kan patient kan. You dah tahu dah certificate difficult intubation, difficult laparoscopy kan. So you can panggil dah lah.
Sebenarnya patient yang kalau keras-keras itu sebenarnya mungkin dia susah. I mean, susah kalau dibandingkan sebenarnya. Sebenarnya patient tu bila keras, patient tu sebenarnya dah mempatternkan airway dia. Faham tak? Dia kan dia breathing. Takkan dia macam kalau dia macam tu dia akan stridor semua kan. So patient yang keras dia dah patternkan airway dia macam tu. You pernah kalau you tengok patient tu, okay, yang panjang-panjang tu fikir kan. So tengok dia punya tengkok macam mana. Dia dah mempatternkan airway dia. Okay, so airway dia okay, tak ada masalah. Okay, so problem dengan tang bila patient tak sedar, tang semua tu lah. So macam mana you kena propupkan patient tu. Okay, satu kena propupkan. Lepas tu macam so bila you nak bayar rumah pun tak ada masalah sebenarnya benda tu. Okay, so dia cara sahaja.
Sebab ideologi tu
So next one is the laryngeal mask airway, which is a type of supraglottic airway lah yang kita design untuk surround and cover the supraglottic area, providing airway protection. Patient untuk dia punya marketing adalah orang yang tak ada intubate boleh pasang LED sebab dia blind jadi. I think correct size. I think correct sizing. So there are many types, tapi yang kita common jumpa adalah yang tiga adalah yang classical, then we have the supreme and the grossil lah. Different yang tu adalah generation. Supreme dan grossil tu dia provide area untuk kita masukkan suction dengan nasogastric feeding lah. Lagi dengan apa, dan ada upgrade kita kata dia boleh see better and such thing tu lah. Okay, so when we see about we need to know how to insert it. As I said, it's a blind method, tapi ada teknik juga lah despite the blind method tu. The first you have to choose the correct sizing. Then when you want to check, macam kita nak check DPT, first you kena make sure dia function. Sebab dia ada this dia punya ni lah kat depan tu, you have to make sure you punya ni function. In order to inflate this, usually when you use LMA, dia akan ada dia punya description how much air you should use in order to inflate each of your balloon lah. So you use that as a guidance lah, kalau you tak hafal, because ada banyak yang sudah hafal, you tengok dia punya manufacturer kat macam mana. Then after you dah checking, no leaking and everything, yes, good to be used. You have to deflate it completely because before you insert information lah. Then when you want to insert, you have to lubricate it to make it easier untuk masukkan. Tapi you nak lubricate belah mana? Belah belakang. Jangan lubricate belah depan, sebab dia penuh fluid dalam mulut patient.
Dia tak guna ni Dr. Husna, semua patient kan nak guna LMA ni.
Patient usually kalau dalam body patient yang short or
Tak mana lama tu nak kat ED ni juga.
kalau
Ha?
PAC,
Okay. It can be your first approach to the airway. Faham tak maksud I? You memang dalam niat hati you, I memang nak guna LMA. Maka you guna LMA. Sebab apa? You estimate that this patient is going to be a difficult intubation. So from the very beginning, your approach to the patient's airway is with supraglottic device. Boleh. Ataupun it can be a rescue technique following a failed attempt. Faham tak maksud I? So maksudnya macam pre-hospital care. Dia kan ambulans bergoyang semua. So they cannot do intubation. So they don't use intubation, laparoscopy, they straight away go with LMA. Boleh. Ataupun you dekat floor. Floor pun dia kata, aku tengok dah macam patient ni kan. Lepas tu EP katakan hari ni kami tak pergi makan kat lunch. So no one's gonna be on the floor. Engkau langsung-langsung ambil. Kan? So kata tak apa, aku nak pakai LMA hari ni. Semua intubation aku hari ni semua LMA dulu. Tapi tak rokit lah kan. Sebab kita prolong ventilation kan. So that's the first approach. Or you dah try laparoscopy tapi you fail. You fail 2 kali. Oh no way I'm gonna get this. Then you're gonna go into rescue. So rescue adalah LMA. Faham? So you decide lah. You decide as you punya primary kan approach you. So sekarang nak buat. Okay.
Okay, kalau first we put lubricating over the posterior portion of the LMA. Make sure your LMA fully inflated lah. Then you insert, you hold dia macam pencil. Jadi orang cakap hold dia macam pencil. Then you replicate dah ni lah. Then you open your mask, you insert it. You insert, dia bukan macam OPA you insert opposite kan. Jadi you insert how you want it to be placed lah. You nak place dia macam
Dia
follow kan. You nak dia duduk macam ni kan. So you have to insert it closely.
Kita nak bagi dia rapat lelaki. Sekarang gitu.
Rapat dengan lelaki. Then you use your finger to push in.
Oh, nak dengar.
Just the face.
Tapi apa ada yang saya lagi? Tak maaf.
Then bila you tolak sampai you have the resistance dekat back of it, make sure you dah sampai ke area dia kan. Then you inflate punya balloon as per necessary.
Maksudnya tak yang ke kiri kanan, dia yang ke tengah. Dia yang ke kat tengah. Okay, dia blind. Ada soalan?
Usually in adult patient, you use size 4 lah. Yang tu yang common size untuk adult. Kalau smaller adult ataupun bigger child, guna size 3 lah.
Tapi ingat ni memang ada tulis punya kebanyakan berapa kilo saiz apa dan berapa untuk inflate pun akan tulis punya.
Jangan terlebih keras kan nanti dia dapat proses tertentu. Saya cium. Okay. Make sure can manipulate lah. Then we have the in order to use you punya extraglottic airway pun ada certain patient yang you predict a difficulty guna pneumonic RODS, RODS. In patient yang ada restricted mouth opening, patient yang ada some kind of jaw surgery ke apa, mulut dia buat satu, tak boleh langsung sebab tak ada yang push in kan. Then patient yang ada obstruction, ada swelling ke inside the throat, janganlah masuk sebab you cause more obstruction. Then distraction or distorted airway and stiff neck pun susah kau nak masuk. You nak masuk. You predicting, kau you tak boleh. You predict it will be hard for you to use a supraglottic airway. This is the summary untuk benda tu.
Ada soalan? Sekejap, ini nak. From the floor, from me, I think this is the what? I question. I just summarize. Okay, when you have a patient with airway compromise, you can actually you can how to say, you boleh nampak dah dia punya trajectory of airway management you kan. So you should start with apa? Should you go straight with the offer or you should start with maneuver first and go straight to the scroll? Kadang-kadang dapat satu station yang DCS 7 macam tu from a stroke. DCS 7 main dekat red zone kan? Dengan stridor. So what should you do first as you approach the patient with regards to the punya airway management? Positioning first. Because you tak main dengan equipment on your body, correct or not? So when you go and first approach the patient, you do maneuver first. Because maneuver requires the least amount of, actually there's no equipment involved pun. It's just maneuver, it's just your knowledge, your technique, your skill. Right? So everyone needs to know how to do head tip chilling. Betul? Ada tak siapa-siapa yang tak tahu kejap. Ada tak? Saya minta tolong try semua orang. I nak tengok. Okay? I nak tengok you buat head tip chilling. Satu. Lepas tu tak boleh juga. You can even do jaw thrust in a non-formal patient pun boleh juga buat jaw thrust. So yang tu, this two is basic. So airway maneuver first and then you go with after airway maneuver, challenging, ada lagi stridor. Ataupun tak rahat dah. By airway maneuver, I mean what? Umi. Or jaw thrust. So this is what we call airway maneuver. So buat dah airway maneuver. Tapi untuk stridor lagi tu. Suction boleh, you may try the suction during masa buat suction nak test apa? Nak test check the GCS dia 7 kan? Okay. So you nak check gap at the first place. Sebab apa? At the same time. Sebab apa? You nak tengok whether you nak tengok lagi macam ni lambat kau nak buat airway maneuver sampai 3 jam. Nak dia buat CT brain lah mana ada. Tak rasa lah macam ni nak kena intubate ke apa, betul tak? So I buat suction, I check dia punya gap. Okay, so now tak ada gap. Letak OPA. Okay, so put in the OPA. The tadi kita dah tunjuk measure the size and all that. Kalau ada gap, dan you pasang nasopharyngeal airway. Habis. Okay, so lepas tu letak apa kat patient? Letaklah oxygen. Letak hydromask, kalau letak gas mask tadi kot lah, depending on how in distress the patient is. So it depends whether you nak proceed that as a pre-op, pre-intubation punya pre-op, then it's up to you according to the case lah, case to case basis. Ataupun kalau patient tu GCS is not too bad, just try out GCS 12 tak perlu intubate pun, you just send the patient like that to the CT scan, betul? So the next technique will be that you have to acquire, which is what now? Your bagging, betul tak? Bagging technique, and bag technique kan? So that one pun kena belajar one hand, in case you're stuck with only yourself, you kena belajar two hand. Okay? Lepas tu, next. Definitive airway. Kalau you tak mau, selit masuk you punya supraglottic device. Okay, faham? So that's how the skill. So as you go along, you go up, you see that the technique, the skill has to be a bit more kena move lah. Rather than just the maneuver kan. So Ali ni main buat very short. Sementara kita nak tunggu radio tu main. Ali ni main buat. Habis dah CME airway. Nak tengok your teknik. Come everyone batuk and main buat set.